Today we want to speak about the new technique of MCL lesion repair using suture anchors augmented by periosteal chamber layer. The authors declared no competing interest regarding the topic of the current study. We propose a novel technique for distal MCL primary repair using the periosteal regenerative potential to enhance the repair quality and prevent future failures. This technique could be applied in the cases of distal MCL tears, in which spontaneous healing is believed to be challenging due to the Passon's ring entrapment. This method of biologic support could also be used after MCL reconstruction surgery. As you know, MRI is the gold standard of the diagnosis for MCL lesion. Painful or limited knee range of motion less than 19 degrees and unacceptable soft tissue are two contraindications for this technique. The patient is positioned supine on the operating table with the injured limb hanging on the table. A well-padded non-sterile tourniquet is placed high on the ipsilateral thigh. The incision is made on the medial proximal tibia extending from the medial joint line to 7 cm distal to the joint line on the presumed location of the superficial MCL distal tibia insertion. Deep fascia is opened carefully with extreme caution not to damage the Passon's ring. Distal superficial MCL is then found in a short and retracted condition by proper dissection of the wound. It is then carefully freshed to remove the crushed necrotic tissue. Because of superficial MCL shortening, the new tibia attachment site was defined as the most distal point without tissue tension rather than the anatomic footprint. The ligament's footprint on the tibia site is then prepared by elevating a window of periosteal flap with distal attachment to provide a suitable bed to receive the ligament. After ligament fixation using a suture anchor, the periosteal flap with distal tibia attachment is turned over the repair site and the periosteum is sutured on the repair site with absorbable 2-0 vicryl providing two distinct tibial attachments for distal superficial MCL. One through the inserted anchors for primary attachment and the other through attachment of the periosteum to bone for future healing.
As a novelty of this technique, we use the regenerative potential of the periosteal chamber layer for better biological healing of the MCL lesion, and it's the most important point of this technique.
The early range of motion is begun in 2 weeks in patients with concomitant ACL reconstruction. Hinge deep raise is continued for at least 4 months after surgery. Toe touch weight bearing is maintained for 2 weeks, and full weight bearing is not allowed until 6 weeks after surgery. In the cases of sufficient muscle force and successful agility training, return to professional sports is allowed after 9 to 12 months. Thank you for your attention. We would be happy to answer any question regarding the topic of this study.